So today I'll be explaining the face and the parotid gland, and I'll try my best to make it as easy as possible. Let's get started with first talking about the regions and the palpable landmarks of the face. So here we have the face, it's continuous with the scalp, and we have here a shared area in the middle called the forehead. One of the most key important landmarks that we need to pay attention to is the temporomandibular joint. It's basically when you feel the head of the mandible, and you feel it mainly when we open or close the mouth. And then we have here the angle of the mandible. So the angle of the mandible is basically where the ramus and the body are meeting, and it's clearly visible on people, but it's rarely obliterated and not seen just in the case of when the parotid gland will be enlarged. And later on, we'll be discussing what is the parotid gland. And then here we have the mastoid process. So the mastoid process, we can see it behind the ear or behind the auricle. Then I have here this region, it's called the parotid region. So this region has the parotid gland that I told you about, and we'll discuss it later on. And we said that if it become enlarged, we will not be able to see the angle of the mandible. Also, what do we have here? We have the parotid lymph nodes, we have periauricular lymph nodes, and superficial temporal artery and temporal nerve. Now, these structures, we'll be paying attention to them later on. Again, if you look here, we have the forehead, we have the periorbital and the cheek, and here we have the nose, and here we have the perioral and the chin area, this area here. And for the mandible, this is the body, and this is the foramen here. This is called the ramus. So I told you when the ramus meets the body, we will have the angle of the mandible, which will be visible. And here we have the head, which we said we can feel it in the temporomandibular joint. We have here the neck, and here we have the coronoid process. Let's move on with talking about the external features and the Langer's lines. First of all, let's talk about the eyes and the nose. So we can see here an area between the eyebrows called the glabella. We call it the bony midline or the glabella because it's meeting the superciliary arches, which are called the eyebrow bones. So I have here an eyebrow bone, I have here an eyebrow bone called the superciliary arches. Now in the midline here, I have the bony structure called the glabella. Then here in the nose, I have what? I have the nasion, which is the root of the nose. So this is the nose. Here, the root of the nose is called the nasion. This one is the nasal bridge. This one is the tip of the nose. And on each side, I have the ala of the nose. Now for the eye, I have here a medial structure and here a lateral structure. The medial one will be called the medial canthus. The lateral one will be called the lateral canthus. So the medial canthus is more rounded. Why? Because inside here I have the lacrimal sac. The lateral canthus is more acute, more sharper. Now, again, I said for the nose, the ala is going to be laterally. It's the lateral cartilaginous sides. And here for the nostrils, we can also call them the anterior nares. Okay, let's move on with talking about the cheeks and the mouth. So in the cheek, I have a bony cheek and a soft cheek. So this bony area and this soft area. Now for the bony area, why is it bony? Because it's overlying the zygomatic bone, whereas for the soft area here, it's formed by the buccinator muscle and the buccal fat. And we are going to take a look at the muscles later on, so put this in mind, buccinator muscle. Then here I have this depression in the middle. It's called a midline depression or called the philtrum. So it's found on the upper lip, and it's ending in the labial tubercle. So it ends here in the labial tubercle, which you can see it as in like the midline of the upper lip. So this is the upper lip. In the middle, I have the labial tubercle. And then on top of it, I have this depression called the philtrum. Then we have folds called the nasolabial folds. So it's from the nose to the labia like this, nasolabial folds. They extend laterally from the nose to the upper lip, and they are visible due to what? because of the muscle tone. But in case of paralysis in the face or Bell's palsy, put in your mind this term, Bell's palsy, we're going to talk about it later on. This will be disappeared. We will not see it. We will not see this depression. We will not see this fault. Now, the Langer's lines, what are they? These are basically the lines of tension because of the collagen being parallel in bundles. Now, why are these important to know for us? Let's say, for example, in surgery, if the surgeon wants to do an incision, they need to do it parallel to the lines. So each area in the body has a certain sequence. It's not all the same parallel sequence. Why do we need to do the incision parallel to it? Because we want it to heal faster and we don't want any scars, or we want a fine scar to appear. For example, in the thyroid surgeries, they do transverse incisions, where, for example, in the neck, they do horizontal incisions. Now, let's talk about the muscles of the facial expression. So they are located in the superficial fascia. And it's very important to know that there's no deep fascia in the face. So for that, it allows for the facial expressions and for the smooth movement. Now, because we don't have any deep fascia, what will happen in this case, if we have a facial wound, let's say for example, it will start to gape. So gape as in like become bigger and bigger. Why? Because of the involuntary muscle attraction that's pulling it apart. So it's pulling it apart and we don't have any deep fascia, so therefore it's going to be more wider in this case. Now, these muscles for the facial expression, they're not only to express emotions, we also call them the guardian muscles. Why? Because they are situated around the eyes, the nose, and the mouth. And all of them, they originate from the second pharyngeal arch. And the second pharyngeal arch actually is innervated by cranial nerve, what? Cranial nerve 7, which is the facial nerve. Okay, let's start with talking about the masseter muscle. Now, the masseter muscle is the muscle from its name, masseter, mastication or chewing. This is not related to the facial expressions, so therefore it's not supplied by the facial nerve. Now let's take a look at this picture here before we dive in by talking about each and every single muscle. So here we can see what the buccinator muscle. And here is the masseter, the one that we just talked about. Here I have the occipitofrontalis, so it's from the front and the occipit. And here we have the orbicularis oculi around the eye. And here we have the nasalis around the nose. And here I have the zygomatic minor and the major. And then we have the orbicularis oculi around the mouth. Let's start with talking about the buccinator, which is this one here. This is the buccinator. So it works to prevent any food to be stuck in the vestibule of your mouth when you're chewing. So this is the mouth, and when you're chewing, you have the vestibule right here. So it prevents the food being stuck in this vestibule while you chew your food, for example. For kids, it's important for suckling, and for us, it's important for blowing if someone is playing the trumpet, or for even whistling, or also smiling. It helps with smiling as well. Now, let's say this muscle has been paralyzed. What will happen? Now, the job of it to prevent food or liquid being in the vestibule, it's paralyzed now, so they will pool in the vestibule, which will lead also to drooling. The substances will start going out of your mouth. The second muscle is the orbicularis oculi, which is around the eye. We have two parts of it. We have the orbital part, which is the one that's outside, and then I have the palpebral part, the ones that on the inside. So the orbital part, why is it on the outside and what does it help? It helps for you to be able to squeeze your eyes shut, squeeze it strongly. Whereas the palpebral part, the one that's inside, is for your gentle blinking, gentle sleeping. You're not squeezing your eyes to do that. Now, let's say if it's paralyzed, what will happen here? It will prevent your eye closure. So you won't be able to close your eyes. Therefore, you will have dryness. Your eyes will be dry. Also, it could lead to corneal ulceration. Let's say, for example, if any substances want to come into your eyes as the reflex, you will close your eyes. Now, this is paralyzed. You cannot do that. So what will happen here? It could lead to corneal ulceration, could lead to dryness, could lead to issues. Okay. As you can see in this picture here, this guy is shutting his eyes voluntarily, and he's it, shut it, shutting it very strongly. Uh, yeah, and yes, so that is for the orbicularis oculi. For the other muscles that I want to discuss, I have the orbicularis oris, the one that is surrounding the mouth. So what does it do? It compresses the mouth shut and also helps in protruding the lips. For the zygomatic minor and major, these one that are here, they are lifting the upper lip, so they are closer to the upper lip, so they will lift it up, and also they will help with what? Smiling, if the person wants to smile. The occipitofrontalis, they elevate the eyebrows, so they're closer to the eyebrow, so they will elevate the eyebrow, but they do not elevate the eyelid. So they will not elevate the eyelid, only the eyebrows. Now we have other facial muscles, muscles of the nose, to dilate the nares, to wrinkle the skin of the nose. We have muscles of the upper lip. They lift the upper lip, they raise the upper lip, they allow smiling. We have the muscles of the lower lip to depress the lower lip and wrinkle the skin of the lip. Now, let's start with the actual depth of this lecture, which is the innervation. So let's start with the motor innervation. The motor innervation is mainly by the facial nerve or cranial nerve 7. Now, what's important to know that the pathway of its originating, it starts where? From the brainstem lecture, it starts in the caudal pons of the brainstem. Then it goes to the internal acoustic meatus in the ears. Then it will go where? To the petrous temporal bone. Temporal bone. And then after that, what will it do? It will exit the skull. So it will go out of the skull through the stylomastoid foramen. Okay? And then it will enter what? The parotid gland, and it will give me 5 terminal branches. So again, originate in the caudal pons, goes through the internal acoustic meatus, goes to the petrous temporal bone, and then exit the skull through the stylomastoid foramen, and then goes to the parotid gland, and there, in the parotid gland, it will give me the 5 branches of the facial nerve. So what are they? We can memorize them by this picture like this, okay? And each position of the fingers are actually locating its job for each and every branch. We can memorize it by the mnemonic to Zanzibar by motor car. So to Zanzibar by motor car. Oh, sorry, car. Let's start with the first branch, the temporal here. So from the position of the finger, what would we expect? What will it supply? It will supply the frontalis and what? The upper orbicularis oculi. And then for the second branch, which is the zygomatic, it will supply the lower, as you can see, the lower orbicularis oculi plus the nasal muscles. Then I have the third branch, which is the buccal. So from its position, it will supply what? The buccinator and the orbicularis oris around the mouth. Then I have the mandibular or marginal mandibular branch. It will supply the lower lip and the chin area. Then lastly, I have the cervical, which will supply the platysma muscle in the neck. Now, if I have what? An injury to the main trunk. I didn't specify a branch. I said to the main trunk of the facial nerve. It would lead to Bell's palsy. I told you to put this term in your head until we reach it, and now we reached it. So what will happen here? I will have paralysis of a half, an ipsilateral half of the face. So it's the same half, ipsilateral, not contralateral. And what will this end up with? Asymmetric flat face. So what will happen here? For example, we will have disappearing of the nasolabial fold. Remember this fold like this, the nasolabial fold, it will disappear. The mouth will start drooping downwards, an inability to close the eye properly. We're done with the motor. Let's go to the sensory innervation. The sensory innervation is by trigeminal nerve or cranial nerve 5. Now it has three important divisions, which are V1, V2, and V3. So V1 is the ophthalmic, V2 is the maxillary, V3 is the mandibular. So let's start with talking about the ophthalmic nerve. So as you can see here, this is V1, V2, and V3. And now this is just the beginning, just for you to assume where it's going to supply. In this picture here, and what are we going to discuss? We are going to see exactly the specific location. So let's start with the ophthalmic division, which is V1. It will supply what? The forehead and the upper eyelid. By what? By the supraorbital, okay, and the supratrochlear and the palpebral branch of the lacrimal nerve. So again, it will supply the forehead and the upper eyelid by three nerves, which are what? The supraorbital, the supratrochlear, and palpebral branch of the lacrimal nerve. And then it will supply again what? The root of the nose, okay? The root of the nose by what? Here, the root of the nose, by the infratrochlear nerve. And then it will also supply the lateral wall of the nose by the external nasal. External nasal. So this is just for the V1 only. Again, let's repeat it. It will supply the forehead and the upper eyelid by the supraorbital, supratrochlear, and the palpebral branch of the lacrimal nerve. And then it will supply the root of the nose, the nasion, by the infratrochlear, and then the lateral wall by the external nasal nerve. Let's go now to the second one, which is V2, the maxillary. So it will supply the cheek bone, by what? So here, the cheek bone. By what? By the zygomatico-facial nerve. And then it will supply the lower eyelid, the lateral nose wall, and the upper lip. So again, it will supply the lower eyelid, the lateral nose wall, and the upper lip by what? The infraorbital nerve. So again, the V2, the maxillary, it will supply the cheeky bone here by the zygomatico-facial nerve, and then it will supply the lower eyelid, the lateral nose, and the upper lip by the infraorbital nerve. Then for the mandibular, V3, it will supply the skin over the buccinator by what? The skin over the buccinator. So remember from the picture, the buccinator muscle was almost like in this area here. It will supply it by the sensory buccal nerve. So the buccal nerve is sensory. So by the sensory buccal nerve. And then it will supply the lower lip and the chin area by the mental nerve. Again, repeating it for the V3, the mandibular, it will supply for me what? It will supply for me the skin over the buccinator by the sensory buccal nerve, and to supply for me the lower lip and the chin by the mental nerve. Now, it's very important to know that you have here, for example, the angle of the mandible, right? So the skin that's overlaying this angle of the mandible, it's not supplied by the trigeminal nerve. It's supplied by what here, the angle, by the great auricular nerve. And this great auricular nerve comes from what? It comes from the cervical plexus. Cervical plexus. So the doctors, they can check this area to see if a patient is faking a trigeminal nerve pain. Okay, now for the ears, we will discuss the lobule first. So the lobule from both sides, they are supplied by the great auricular nerve, and we said it's coming from the cervical plexus. And then from the outer surface, so the upper outer surface here, it will be supplied by the auriculotemporal nerve, which is branch of V3. What is V3? Mandibular. So mandibular will give me auriculotemporal, which is supply the outer upper two-third surface of the ear. And then the inner surface, okay, upper two-third inner surface, it will be by the lesser occipital nerve. Now let's talk about the blood supply and the venous drainage. Let's start first with the arterial supply. It's very important to know it. So it's very important to know that our face in general is highly vascularized. What does this mean? It means it will bleed a lot, but it will heal fast. because it's highly vascularized. And it's very important if in the face I have any stitches to be removed after 2 days. Why? To avoid any scars. So if there's a scar, we need to remove it. If there is a stitch, we need to remove it to avoid the scar. Now, if we take a look here, I have the external carotid artery. Now, this one, it will give me the facial artery, which is this tortuous artery. And we'll get to know why is it tortuous. So again, it comes from the external carotid artery. It will cross the lower border of the mandible, okay, where we can feel the pulse of it right here. And then it will go up and it will end in the medial angle of the eye. Now, it's tortuous in order to accommodate or be able to handle the chewing of the mandible. So when we are opening and closing the mouth and chewing, this facial artery, it will be able to handle it. That's why it's tortuous. And we said it will terminate in the medial side of the eye, right? So there it will terminate as what we call the angular artery. So it will terminate as the angular artery, and then it will anastomose with the ophthalmic artery, which is a branch of the internal carotid artery. So what does this mean? The internal and the external are anastomosing. They're creating a pathway that if one of them is blocked, we can do ligation and use the other one. So again, let's take a look here. What will happen? First of all, what we need to know about the facial artery is that it's superficial. It's not in depth inside any deep fascia or any muscle. It's superficial, meaning it only has a skin, fascia, and fat. That's it. And there's the pulse point, which is in the mandible and the mouth angle. And we have other pulse point for example, superficial temporal artery, which will be over the zygomatic arch, the one that we talked about, the zygomatic arch like this. It's tortuous to accommodate the mandible movement. And we said that the external internal carotid, they will do the junction. Why they will do the junction, I'll explain again. So it will start from the external carotid artery. Which one? The facial artery. It will start and it will go and hook around the lower mandibular border. So it will be around the lower mandibular border. It's basically around the area like anterior of the masseter, and then it will carry on upward and forward. So again, the lower border of the mandible goes to the angle of the mouth. It will be 1 centimeter lateral to the angle of the mouth, and then it will go up lateral to the nose and then terminate in the medial eye as angular artery. It will give me branches, by the way, which are what? These branches, superior and inferior labial branches, which will supply the upper and the lower lip, and it will give me also nasal branches. Okay? Now, once it terminates as the angular artery, we said it's going to anastomose with the ophthalmic artery. And when it anastomoses with the ophthalmic artery, which comes from the internal carotid, this means that I will have a connection between them. They will have a junction at the eye, which will allow for an alternative supply and safe ligation. If one of them is blocked, we can use the other one in surgery. Now, moving on with talking about the venous drainage and the dangerous area in the face. Now, the dangerous area in the face is basically, if you look here at this picture, it's between the root of the nose and both angles of the mouth. So let's say, for example, this is the nose and this is the mouth. So between the root of the nose and both angles of the mouth. Okay? Now, if we have here, for example, bad acne or furnicles, or bad hygiene in general, what will happen here? It will lead to infections. It will lead to a dangerous infection that will affect the cavernous sinus, and we will take a look at it right now. So, it's infectious and dangerous because of the anterior facial vein connect directly to the cavernous sinus. As I said, it will lead to infection in cavernous sinus. Let's dive deep into it. Okay, so let's take a look here. What are they telling us? That in the scalp, okay, for the drainage, I have certain veins. For example, I have the supratrochlear vein, I have the supraorbital vein, I have the superficial temporal vein, I have the posterior auricular vein, and I have the occipital vein. These are the main, for example, scalp drainages. Obviously, there's others. You can get to read them. It's fine. But the most important thing that you need to take from this slide is that these valves, these veins, they are valveless. Meaning what? Meaning what? Meaning they allow retrograde flow against normal, meaning it's easy to have an infection that will spread because it doesn't have the door that stop it from not going back. They are valveless. Now, how can this infection happen in the dangerous area? It can either happen directly going through the eye or indirectly going through the pterygoid plexus. So if it's going directly through the eye, it will pass through what first? Through first the facial vein, and then it will go to the angular vein. Now the angular vein, this is worth noting, that the angular vein is basically a junction between two veins, which is the supraorbital and the supratrochlear. Okay, now when these two have a junction between them, they form for me the angular vein. And then from the angular vein, superior ophthalmic vein, which goes directly through the orbit, that's why I call it direct route, and then goes to the cavernous sinus. Or it can happen indirectly, again from the facial vein, which is in the dangerous area, and then the deep facial vein, which is deep in the cheek, and then the pterygoid plexus, then the emissary veins, which are the veins that are connecting through the skull, and then through the cavernous sinus. It's very important to memorize these two pathways. Eventually, what is the outcome? We will have cavernous sinus thrombosis, which is dangerous clots and damages to the nerves. Okay? Now, this thing could be more prone to people who are immunocompromised, diabetic, or have vascular diseases like heart disease, like hypertension, and all of those. So, I hope I made it clear. And I believe that this is the most important thing that we might get questions on. Now, let's move on to talking about the lymphatic drainage. So the lymphatic drainage is basically the opposite to the arterial pathway. Meaning what? Meaning that it goes down. It goes from the scalp to the face to the neck. Whereas the artery, no, it goes from the heart to the face to the scalp. It goes up. Now we have four of them. I have the buccal, preauricular, postauricular, and occipital. So the buccal, it's over the buccinator. It's over the buccinator, okay, and it drains what? It drains the face, the eye, and the nose. So the front of the face, the eyes, and the nose. The preauricular, on the other hand, is basically superficial to the parotid gland. And again, we're going to talk about the parotid gland later on. And then we have the postauricular, which is the mastoid, which is behind the auricle. And then I have the occipital, which drains the posterior scalp. All of these eventually, they will go to the cervical node in the neck. Okay, now for the parotid gland, it's basically what? It's the largest salivary gland. And it's found mainly here in front of the ear and extending over the angle of the mandible. So in front of the ear and angle of the mandible, approximately. Now, in children, it mainly become infected because of the viral epidemic parotitis, and it will lead to the mumps disease. So the mumps disease is happening because of infection of the parotid gland in the kids, where this gland will become swollen and it will obliterate the angle of the mandible, as I mentioned in the beginning of this video. Now, this inflammation, it will be extremely painful. Why? Because this gland is basically in a fibrous capsule. So imagine it. Let's say this is the fibrous capsule and this is the gland. If it's becoming swollen and big, it cannot exit because this capsule right here is very rigid. It's very rigid. Okay, it's non-stretchable. That's why it's very painful for them. Now, if I want to talk about the contents of the parotid gland, I can make it easy and say we need to memorize it from superficial to deep. Okay, so the most superficial one that we can see is the facial nerve or cranial nerve 7. And then I have the retromandibular vein. And then I have the external carotid artery. And this external carotid artery, it will give me two branches, which are the deepest ones. It will give me the maxillary, and it will give me the superficial temporal artery. If you memorize it in this way, everything will be good. Okay, so again, I have the parotid gland. Okay, and in the next slide, we're going to talk about this parotid duct and why is it very important. Okay, again, this is the parotid gland. And this is the contents. I've just made it easier and told you to memorize it from superficial to deep. Now, if we want to do any surgical incision here, it needs to be what? Horizontal. Why? Because it needs to be parallel to this facial nerve that we said it's most superficial. So it needs to be horizontal and parallel to it to avoid cutting the facial nerve. Now let's talk about the parotid duct, also called this the Stencer's duct. Okay. Now it's 5 centimeter long, as you can see here in this picture. It's 5 centimeter long. Okay, and it's horizontal below the zygomatic arch. So it's horizontal. If I have the zygomatic arch here, it will be below the zygomatic arch and horizontal to it. Now, it pierces, as you can see here, the buccal fat and the buccinator muscle. Why it does this piercing? Because it needs to empty into the vestibule of the mouth. And where will it be emptying? This area here, exactly the location of it, is opposite to the upper second molar tooth. So opposite to the upper second molar tooth. Memorize this because it would come in the exam. Now, how can we draw a line, for example, and know the exact location? So we can take the area from the tragus of the ear and we do a line which will be midway between the ala nasa of the nose and the angle of the mouth. So it will be in the middle 1/3 of this line. It will be approximately in this area. We call it the surface anatomy of it. And I will end this lecture with some questions that you can pause the video and revise them and try to answer them. I hope this lecture was clear and easy. Thank you very much for listening.